So what do we do for these babies? What do we do for them while we're scoring them? And if they don't yet meet the treatment scoring for the Medicaid-assisted treatment, which I'll tell you about, we start doing non-pharmacologic treatments from birth. So for these families, we teach them, and we have a special room in our nursery where the environment is quiet, the lights are dim, and there's no TVs or mobiles, so very little stimulation. We swaddle or wrap these babies snugly, and they love being held in a C-curve position. And a C-curve position is when we take their knees and we bend them up to their chest and hold them in that C. Also, we handle them gently, and we avoid any jerky or sudden movements, and we hold them firmly and close to our bodies. Now, we do have a cuddler program here at Wheeling Hospital, and this is a group of ladies who, many of them are grandmothers, retired daycare workers, retired teachers, even some retired nurses, that will come in and volunteer their time to sit with these babies. Many times moms are busy with other siblings, or maybe they're in a treatment unit. Sometimes they go to jail. So if the moms are not present, we do have cuddlers that can come in and hold these babies in that C position. And we do have training programs for these cuddlers, because often these babies are on different machines, such as heart monitors and respiratory monitors and things like that, that aren't just like holding a normal baby. What else can we do? Well, we can encourage skin-to-skin holding with the mother to promote bonding. So in this dark, quiet room, we'll also have the mom do skin-to-skin to comfort her baby. We'll teach them gentle rocking, holding their baby in a C-curve, soft singing, humming, or sometimes just a repetitive shushing sound. And we limit stimulation at the first signs of distress. So some of these babies don't like being sung to. Some don't like the humming or the shushing noise. These babies, we do offer a pacifier for non-nutritive sucking. These babies are comforted by the binky. They do feel better when they actually have something in their mouth sucking, and it will save the sucking blisters and the red and infected fingers that can happen. And then also a sling or an infant carrier, and even our nurses have infant slings and carriers that we would use for these babies. Another thing that we've fell in love with is a mamaroo. And if you've never seen a mamaroo, it's like an infant seat that you can set automatically to sway and make shushing noises. Some other nursing measures, we use gentle touch and voice to awaken and prepare these babies for care. We maintain the swaddle position, and when we do these babies' cares, we keep them wrapped up as much as we can. And when we do unwrap these babies, we use hand containment and a binky. So we will actually hold these babies with the palm of our hand in a tight position, even when we're listening to them breathe or to their heart sounds. And then certainly when we're done, we re-swaddle these babies and offer them back their binky so that they have some comfort. For feeding, these babies have a really difficult time feeding. It seems like they just can't get it together in order to suck and swallow, and so they're pretty miserable from hunger and from belly aches from all the air they take in. If a baby absolutely cannot eat, we will put a nasogastric or an NG tube down these babies and give them their feeds while they're sucking on a binky. We swaddle these babies as they eat and pull their hands into the midline. They seem to do better if we cross their hands over their bellies or their chests. We offer firm input to the baby's feet, so we sit in a rocking chair with the baby straight up and down with his legs bent and his feet straight up and down on your lap. We keep input and stimulation to a minimum, so it's a dark, quiet room that the rest of the normal newborn population is not in. We may place a hand over the infant's chest, so we hold the bottle with 2 fingers, and with our other 3 fingers, we're pressing firmly on his chest. And we can offer firm pressure to his palate to increase the quality of sucking. So sometimes you have to put the bottle in the baby's mouth and use 2 of your fingers to make his chin go up and down so that he gets the idea of sucking and swallowing. Now, obviously, our first choice is human milk, and the mom's own milk is preferred if she is in a methadone or Suboxone treatment program and is compliant. However, if there's other suspected substances of abuse, the mom should definitely not breastfeed. So babies or moms who come in that have been taking drugs off the street, it is simply not safe to let them breastfeed. But moms who are in a controlled Suboxone program, who are in a clinic, who are taking their prescribed Suboxone, we prefer them to breastfeed, and then we assist them with weaning when they're ready to wean from breast milk. And yes, these babies do often need treated with morphine as well. Now, if there is no human milk available, then we would just use a standard formula. There's no evidence for using a sim-sensitive or Gentle-Ease or any of those easy-on-the-belly formulas, although we will try that if general formula is not helping. But right now, we don't start off with any special formula. We just haven't seen the value in that. Now, loose stools, they can be the result of inadequate coverage of medication. So maybe we're not giving the baby enough drug. Maybe we're allowing the baby to withdraw too much. Not usually lactose intolerance. However, when a baby has consistent diarrhea for the first few weeks of life, he can develop lactose intolerance. So if patients are well maintained on pharmacologic treatment, hopefully there'll be no diarrhea. So pharmacologic treatment consists, our hospital uses morphine in tapering doses. So once a baby scores 2 8s in a row on the Finnegan scoring system, or 112, we would implement morphine. And it's a weight-based dose, and we wean it every other day as long as the scores stay less than 8. If persistent diarrhea occurs, we can try a lactose-free formula. And before the baby goes home, though, we try to get them back on regular formula. We work closely with WIC programs so that they get the correct formula that they need. And like I said, we don't routinely use a sensitive formula, but it is an option if we need to. Now, all of these babies need some kind of diaper barrier cream right from the start. We use Aquaphor or Desitin or whatever barrier you want to use, and we use this on every diaper change. If it becomes irritated, we might change to Desitin all the time. But we've also done some oatmeal baths on their bottoms. We've used oxygen blow-by to their bottom area. We've even made little baby spas and put their bottoms down in warm soapy water and created bubbles. We do all kinds of things to keep these babies' bottoms clean and healthy. And luckily, in the last year or so, we haven't had any problem, because I think we pretty much have the barrier cream treatment down pretty well for these babies. Now, remember I said that other areas of these babies can become excoriated, the backs of their heels, the backs of their heads, their elbows, and we would use Aquaphor on those. And then we also have 2 products that are more or less like thick Band-Aids called Tegaderm or Duoderm that can be placed over their elbows or whatever part of their body is rubbing against the bed, just to protect it so that it doesn't have further irritation or breakdown.